Yeah. Good evening, everybody. We are here again on ILD MDM Friday. I start telling it ILD MDM Friday from now onwards. And we have Dr. Vimal Raj as a radiologist expert today. Along with us, we have got Dr. Sharda, who is a lung transplant pathologist. Basically, she has interest in lung pathology and she's working in Hyderabad. And we have got Dr. Partha Sarthi and Dr. Susmita Roy Chaudhary, both from Kolkata. And we are really lucky and honored to have you both over here, along with Sharda and Vimal Raj sir. Bhavin sir and Sujit Rajan sir are always there. We have 3 cases, and without further ado, I will start sharing my screen. The first case will be presented by Dr. Pradeep. And just 1 second, Pradeep, I'll start sharing my screen. And yeah, I hope it is visible and it is moving, right?
Yes, ma'am.
Okay, go ahead. All yours, Dr. Pradeep.
Okay, ma'am. Thank you. A very good evening to all the respected seniors, my dear colleagues. Without wasting any second, let's start from the very first case. We had a patient presented to us. It was time duration in the last year, in between Feb to April, near about March of 23. We had a patient, 68-year-old lady that presented to us to our hospital with complaint of the worsening of breathlessness for the very last day, 10 days. Apart from these 10 days, there was also history of gradually progressing dyspnea for the last 6 months. The very new onset symptom was a fever that was associated with the chills for the last 2-3 days. Apart from these fever, breathlessness, there was also history of toothache and some UTI-like symptom, burning, micturition, and lower abdomen pain was also there. Uh, from the lady's personal and the social family history, she was from Faridabad, Haryana. By occupation, she's been homemaker the whole life. Uh, there was as such no disease history of the diabetes CAD to the per se to the patient, but there was family history of the diabetes CAD was there. One peculiar history was that the lady's keen interest was into the feeding to the pigeon. So there was direct significant pigeon exposure was present. She used to feed the pigeon near about her flat in the courtyard in front of the patient's house. There was no any peculiar joint or rheumatological symptoms was present. Uh, in the past history and the treatment of comorbidities, there was no history of diabetes, hypertension. There was a positive history of the osteoporosis for that. She was on teriparatide injections. There was multiple episodes of the UTI for 3 times in last 2 years. That the UTI symptom on the detailed evaluation by urologist uh, was attributed to the uterine prolapse and the cystocele diagnosis. As I mentioned that she presented to our hospital, not to our department. She was admitted under internal medicine department with the suspected diagnosis of the urosepsis as well as the breathlessness symptom was also there. Pulmonary medicine consultation was taken in view of the consolidatory finding in chest X-ray. There was left upper as well as the mid zone consolidation was there. After our consultation, we advised to get a HRCT test because of the long duration of the dyspnea symptom and the persistent oxygen requirement on the clinical basis. We got a CT chest, HRCT thorax in first hospitalization.
Okay. Vimal Raj sir, would you like to share now, or shall we just finish discussion and?
I think much better now, no?
Okay, fine. I'll stop sharing. Yeah.
The reason is this patient has got 2 CT scans and they are quite as a follow-up.
Yes,
so let me.
So I think we will because there are 1, 2, and 3 CT scans which we have to see serially. So what we will do is if you can little bit faster summarize, Pradeep, because we have two more cases,
Yes,
and
yeah,
then we
yes,
have
ma'am.
to. So I do not think we have to read through all the slides. Please tell, because you know the case. Just go. I'll start sharing, but I want you to just summarize whatever is relevant.
Okay.
Okay, so please,
I'll be much
we
more
will,
quicker.
yeah,
Yes.
we will quickly just go through it. So, yeah.
Based on the radiological finding, there was pneumonia as well as the urosepsis. So patient was started on the piperacillin tazobactam as well as the IV doxy, and there was blood profile testing was suggestive of sepsis in the blood culture, and our blood culture report there was E. coli grown. Cardiac limitation was also there. There was grade 2 LV diastolic dysfunctioning was there. Pulmonary hypertension up to extent of moderate to severe was present. RVSP was around 50 in the bedside echocardiography. So after resolution of the pneumonia and dealing with the UTI, patient was discharged on the oxygen and oral antibiotic and advised to come for the follow-up in the pulmonary medicine OPD. But as you know, most of our Indian patient, she was lost to follow-up. She was under another tertiary care center in the Delhi in that March to April 2023. Sorry for the correction, it was 23. And in that center, she was diagnosed with fibrotic NSIP query and query fibrotic hypersensitivity pneumonitis. The ILD workup was thoroughly done. There was complete rheumatological panel was done that was negative. Though HP panel was strongly positive for the Pigeon avian protein antibodies as well as the Aspergillus and penicillium antibodies. So she was in view of the diagnosis of ILD, she was started on I don't know what was the dosing, but it's again a not accurate dose. She was on started with directly to 20 mg of omnacortil MMF in form of 500 BD and upfront antifibrotic in the dose of 150 mg twice daily. As all the OPD prescription from outside hospitalization or the OPD visit, we got some details about the lung function. We didn't get any PFT reports printed. So in some of the OPD prescription, once lung function was done and her lung function was labeled to 1.2 liter FEV1, 1.42 liter of FVC. DLCO was lesser than 40% to severe extent. There was significant walk distance limitation was there, and she was desaturating to extent of 80% just after 2 to 3 minutes only. That lady was again presented to our hospital, this time admitted under gastro medicine department in view of persistent diarrhea. So again, pulmonary opinion and obviously the gastro input was made. So nintedanib was stopped, MMF was stopped in view of the diarrhea situation. Our opinion was taken. That lady was started on oxygen. First time home-based LTOT was prescribed. Pulmonary rehab was done. The dose of prednisolone, which she was on 20, that was maintained. Again, asked for a detailed workup evaluation. And at that presentation, she was also unable to do PFT. And the 6-minute was test was performed, but she didn't interested at all because of significant hypoxemia even in day-to-day activity. So we got another chest CT scan for the workup of the ILD. So again, that lady was asked to come for the OPD follow-up, but the same scenario happened. She was again lost to follow for the next 2 days. Next 2 months, sorry. After 2 months of that visit, she again presented to our department. All the emergency visited was to our hospital. It was because she was nearby to the Amrita Hospital, Faridabad. That's why all the ER presentation was to our hospital, while the OPD consultation was to the different center. So she presented to ER with slurred speech, altered talk and drowsiness and altered behavior in October to November
Pradeep,
2023.
sorry if I can interrupt. I didn't want to do this, but Asmita, maybe we can just shift straight away to the question to be answered and then move backwards for the history if required.
Yeah.
Because this is just going on and on. So
Yeah, I will.
Sorry,
I'll.
Pradeep, to interrupt, but I think we should just, it's we don't have a
Yes,
lot
sir.
of time for
Yes,
these cases. So
that
why don't we
that's
switch to the last slide where you have a question that has to be answered, then Vimal will take over and sort
okay,
it
sir.
out.
Yeah.
Uh, So, sir, basically, in that patient, the first CT that was it was a HP-like finding, and again the HP panel was positive, and all the rheumatological profile was negative. So the first diagnosis was HP, but in the third admission, when she was hospitalized under neurology, the diagnosis of hypercalcemia was made. So the MRI brain was normal, all the neurological rest of examination finding was normal. So in view of hypercalcemia and with fibrotic ILD, after taking our opinion, we thought why not it's possible to be sarcoid. So we got a PET CT done, and in the PET we got a large shining spleen and a few 2 to 3 centimeter size around retroperitoneal lymph node uh, that's shown in the PET CT image. So the CT-guided biopsy was taken from the retroperitoneal lymph nodes, and the diagnosis of sarcoid was kept in the differential possibility. Our question here is, was it ever HP? The first question, because on the basis of uh, the radiology finding, the exposure to the direct exposure
Yeah,
to the
that
fission.
we will say. So was it ever HP or not? Then rest of the question will take as it comes.
Yes.
So Vimal Raj sir, you can, all yours.
Uh, and stop, please.
I did no.
Yeah, okay, thank you. So there were 3 CT scans for this patient, and I hope you're able to see the 2 CT scans. This was the initial CT scan which had happened. And at that point in time itself, you're able to see large areas of consolidation in the pleural effusion and smaller right pleural effusion that the patient had presented with, even at that point in time. A few things which were very atypical at that time were lots of lymph nodes, and some of these lymph nodes were showing central areas of calcification and some peripheral areas of calcification. You can see across bilateral hilar and mediastinal lymph nodes. Now, if we look at a follow-up scan, this is the follow-up scan of the same patient. The consolidative changes are
Your voice is breaking, Vimal Raj sir.
glass opacities, reticular change, traction dilatation of bronchi, and some patchy areas of subpleural cystic changes as we go down to the bottom. Now, these similar things were present even then in the prior scan where you were seeing all the mosaic areas of air trapping was also visible even at that point in time. So I can definitely understand why it was called as HP at that time, but there were lots of other features which were atypical for it. So the most recent scan, I'll just show a couple of things quickly. Lots of lymph nodes that we can see across here. And as we go down further, the liver is enlarged, the spleen is quite big. There are all these retroperitoneal and perimesenteric lymph nodes that we can see.
Yeah, I think Athol Well sir has joined and he's telling it is inaudible. I'm not sure. Anyway.
Are you able to hear me now?
Yes, we are.
Okay. So the interstitial changes remain pretty much the same. The consolidative changes have definitely improved. So there is
We lost it again, sir. Yeah. Are you muted, sir?
Sorry, no, I think my network is having some problem. I'm just going to switch over to some better network in just 2 seconds.
Sure,
But
sure.
in summary, I was just saying that interstitial changes all fit very much with a chronic HP picture. But then there were a lot of other changes which are very atypical, which we are looking at lymph nodes, hepatosplenomegaly, which all fits in with sarcoid.
Yeah. So I'll just quickly go through the questions again. And 1 second. Share the screen. So was it ever HP? Was it ever HP? Can we say panel?
Yes, I
Yeah.
would say it was.
Okay. It was. And you confident about it that it was because of her pigeon exposure or because of the CT findings, ma'am? Because I think because quickly going through the biopsy slides, which is very classical, I would say. Sharda, if you can just quickly, I have only 30 seconds or 1 minute for your comments. Can you please quickly say that is this definite sarcoid? Or can it happen in HP also? That's the
No,
question.
so what the biopsy pictures are showing are a well-differentiated, well-delineated granulomas, which are non-necrotizing. And here we could find this multinucleated giant cells with asteroid bodies. And this reticulent staining is highlighting the onion skin fibrosis. So so in hypersensitivity pneumonitis, you don't find these demarked granulomas. They are usually very vague, non-necrotizing granulomas, and it's like literally you have to search for the granulomas in case of hypersensitivity pneumonitis. So I favor a diagnosis of sarcoid based on these biopsy pictures.
Okay, Katrina, do you still believe that it was HP or would we just go with a fibrotic sarcoidosis? All the panel, madam, Partha Sarthi sir, Katrina madam, and Wells sir if he's there.
I think we have to keep in mind that if a person has got history positive of exposure and I have a lot of problem to listen to others, but the fact is that if there is a precipitin positivity to any antigen for HP, and if the history suggestive of exposure is there, the odds for having HP is very, very high. It's close to 30. So, and the CT scan also, the HRCT is also suggestive of HP. So I think HP is there. And I believe there are two pathologists working in this patient. Why not two together? Because the kind of granuloma being shown are classical of sarcoid, and this kind of clear granulomas have not been seen in the HP. So I think two pathologies are together. It's a rare combination, but it is a fact. This is my impression.
Yeah, Katrina, please.
Yes, I think that, as you said, as we have these granulomatosis, let's say.
I want to comment about the calcium.
Hello?
Yeah, please go ahead, Katrina.
Yes, we have a fibrotic disease at the end of the day. So I think that even if you call that a fibrotic HP with a mixture of some sarcoid antigen interactions, I don't think that changed a lot the prognosis at that stage, unfortunately, for the patient. So if I would classify this diagnostically, I would prefer to put that as a fibrotic granulomatosis disease, which didn't respond to immunomodulation and antifibrotics. So I would, refer the patient to a transplant center. The problem is that she's aged 68, so I'm not sure how you can proceed with this. And I would have a look also in the pH component, which these values of 50 usually have to be further investigated in this parenchymal disease and could be more related to a sarcoid reaction. So pH related to sarcoidosis, to fibrotic sarcoidosis. So what to treat is what is treatable. So I would add on beyond of the treatment that you do, the oxygen, the rehab, I would do the assessment for pH, and I would add some diuretics because I also see that the patient has a higher BNP. So that's are my thoughts. If I could add something to
Sure,
your
sure. Yeah, got it. Madam or Parthasarthi sir, you were talking something about calcification. We lost him. Susmita madam or
Yeah,
Rajan sir.
no, I
Yeah.
completely agree. The initial picture, the history wise and the radiology were pretty much in keeping with HP to begin with, but the ones that you showed next had significant calcification, and then along with the pathology that was presented, that is in keeping with sarcoid. So she probably has, as Katrina said, fibrotic granulomatous disease, and there's sarcoid transformation as well. PET-CT would be positive in acute phase of HP as well. So, but definitely the pathology is more in keeping with sarcoid. So we would continue with glucocorticoids. The pulmonary hypertension could be related to long-standing hypoxemia. So we would give them oxygen and pulmonary rehab, and also look for, the other extra panel to look for other causes of pulmonary hypertension. And at 68, I don't think she's going to be a lung transplant candidate, at least in our country.
So I think the last two question, importance of HP panel and all, is not possible, Pradeep, to discuss over here. We'll just go to further management, and as Katrina suggested, we can do either lung transplant. Regarding medical part, are we agreeable to what is going on, like nintedanib? Rajan sir, do you think this is progressive, like a pulmonary fibrosis kind of picture, and can we continue what we are doing? Patient is on nintedanib, right?
I
Or
was
another?
just yeah, I was just trying to get the history a little sorted out because there was a lot on the history. Is this patient on steroids all this time, Pradeep?
I think so.
Sir, the first presentation was with pneumonia. After that, she was lost to follow-up. Then from outer side, she was started on steroid. So she has been on steroid, though it was not, to be frankly saying, not adequate steroid. The first
But has her
prescription we
lung
got was
function
20 mg
improved,
only.
Pradeep? Have we gained vital capacity on steroid?
Sir, we got only single PFT report, but
Oh,
if we consider the oxygenation status, so oxygenation wise, there was definitely a declining of the lung function and increasing oxygen requirement.
yeah.
But
So
that way,
Because
even
disease was
Vimal Raj
yeah,
sir,
it is
CT was
been
progressing, na sir? I think.
yeah. So the thing is that the history of an allergen, like pigeon dust, is pretty common. Those granulomas definitely look like sarcoid granulomas, what was described, very well formed, tight granulomas. I would rarely see such granulomas in HP. I mean, we very rarely see that. So I think there is a background sarcoid for sure, whether there's associated HP. And now she's oxygen dependent, you said, Pradeep?
yes, sir.
Yeah, so she's definitely a candidate for transplant. She'll have to be counseled for that if she uh, can
Agrees.
access transplant. But now it's progressive fibrotic disease, and you have granulomas, clear granulomas. So this is unusual for sarcoid to progress that much. I mean, you have a small percentage of sarcoid that develops progressive pulmonary fibrosis. But
Did she like?
sorry.
Sir, I have just a single question. Just the what we have very much clear that the disease is progressing. So suppose it's a sarcoid with HP. So if the disease is progressing on the sarcoid side, the what should be the immunomodulation? Should we
Methotrexate.
continue?
Methotrexate
So
would
again,
be,
sir,
yeah.
if we consider sarcoid with HP, so should we take a risk of starting methotrexate because it's a non-drug to cause HP as well. So
No, no,
we
no.
should
No,
think
no.
about
Methotrexate is not
azuran
a
or
common
Yeah.
common drug to cause HP. Don't worry about that. And
okay.
methotrexate causing interstitial lung disease itself is
Very, very.
quite rare. In fact, we give it to our patients with rheumatoid arthritis with early ILD as well. And they improve. So don't worry about giving methotrexate to a sarcoid river, though it's not going to make any magical difference right now. The way the disease has progressed, I think it's better off she's on oxygen, supportive care, manage her symptoms, and an antifibrotic for whatever it's worth, I think should start now. And transplant counseling. I mean, I don't know if Sushmita or Partha would have anything more to add to that.
No, I agree. It's just that trying to find out if she actually had steroids for an adequate period in an
Yeah,
adequate
that was
dose in the
important.
first
Yeah,
place. Otherwise, I would do that for the first 2 months and see if that benefits her hypoxemia a little bit or not.
I
So
agree.
are we having consensus diagnosis of fibrotic sarcoidosis, and the
Yeah.
treatment plan will be to consider increased dose of steroids along with another disease modifying agent, probably methotrexate.
Sure.
So shall we just move on to the next case? Or
I think based on what Partha and Sushmita also, what we all seem to feel is probably progressive fibrotic sarcoid with a moderate level of confidence, I think. Huh?
I think.
Yeah. Vimal Raj sir, anything to be added from your side, sir?
I'm just going to differ in
I
saying
think we are not
I
yet
think-
sure that.
Yeah.
Yes.
May I interject?
Yeah, sir.
Yeah, what I would suggest to go for a PET CT. Does a PET CT shows a high uptake in the lung parenchymal zones or not?
Was it showing, Pradeep?
The PET CT has shown
No,
splenic uptake.
Not
But what about
uptake
the
in the lung.
parenchymal?
No. Lymph node
So
only.
it's almost fibrotic disease.
Not much. So it's
no lung
unlike,
activity.
so if had it been sarcoid, the chance of high uptake in lung parenchyma was there.
Okay.
Vimal, what was your point, Vimal?
My point is that I think it's a dual pathology. I think even at the initial presentation, there was a lot of fibrotic change which was already there. So I think there is a fibrotic HP which is going on in the background, and there is sarcoid on top of that.
I agree with that.
Yeah, even Katrina said the same thing. So I think, maybe coexisting. It was dual pathology, and whatever possible you people did. So I believe we should move on to the next case. Thank you so much, Pradeep. I will move on to the next case. So, Vidya, are you ready?
Yes, ma'am.
Okay. I think is this your case? Just check it. Yeah. Sure. All yours.
Good evening, Manal. Present here. I'm Dr. Vidya Nair, Registrar in the Department of Respiratory Medicine, KIMS Health, Trivandrum. I'll be presenting the clinical details on behalf of Dr. P. Arjun, sir. Moving on to the clinical details, our patient is a 40-year-old male who's a software professional. He was a non-case of systemic hypertension and hypothyroidism on regular medications. He presented to us with history of progressive breathlessness for 6 months, which was of grade 1 to 2 mmRC. And he also gave history of occasional cough, which was non-productive. He didn't have any wheezes. There was no orthopnea. He didn't have any fever or joint pain or stiffness. There was no skin rashes, no history of photosensitivity, any dysphagia, or any muscle weakness. He had a few significant histories. He gave history of vaping for 1 year almost. He was vaping almost every day. And he also gave history of staying in a high-rise building. There was exposure to pigeon, significant exposure. He also gave a history of exposure to moles at home. His general physical examination was unremarkable. His vitals were stable on presentation to us. He had a saturation of 98% on room air. On auscultation, he had bilateral basal fine crackles. And his routine labs were all within normal limits, except for eosinophil count of 7.5% and AEC of 520. And his pulmonary function test showed apparent restriction, and DLCO confirmed it. The DLCO was reduced, it was 55%, and KCO was 70%. And VA by TLC was increased. So we had his rheumatology workup done. The ANA-IF showed 3+ nucleolar pattern. ANA profile showed RO52, borderline positive. The rest all were negative, and in myositis panel, OJ was borderline positive. Rest all investigations, including RA factor, anti-CCP, ACE, were all negative. His cardiac evaluation was normal with an echo. We did, it was normal. Meanwhile, we sent a HP panel. It showed penicillium, cladosporidium, aspergillus, and alternaria. So we had a rheumatology opinion also. Considering the disparity between the clinical presentation and the radiological findings, we had a possibility of E-valley in our minds. So we decided to proceed with the rigid bronchoscopic cryobiopsy for the patient. Ma'am, are we discussing the CT now?
Yeah.
Okay.
Vimal, sir, yeah.
Yeah. So I've got 3 sets of CT images for this patient and quite interesting pathology. So coming from the left side to the right one is the most recent one from May 2024. The other ones are from prior studies. And what you can see across here, let me just get that back. Yeah. So what you can see across here are these diffuse areas of ground glass opacities, which are spread throughout the lungs in a bronchocentric distribution. And they are pretty much everywhere as we go from the top and as we go down to the bottom, more so in the lower lobes. A few things which are of interest if we see in the most recent scans here, in the lower lobes, you're starting to see some early cystic spaces which have started to come up in the lower lobes that we can see here. No honeycombing as such, not much in terms of other concrete nodules, but these are themselves centrilobular bronchocentric ground glass nodules. So again, subpleural changes around here in the anterior aspect of both lungs. There was no air trapping. There was no air trapping on expiratory scans. And when we looked at lymph nodes, etc., there was nothing in the mediastinum which would help us with any of the pathology. So you can see the middle one is an expiratory scan. There was no air trapping at all. So what I'm seeing here is a acute to subacute process with lots of centrilobular ground glass nodules with some subpleural cystic changes. So this is in keeping with an interstitial process which is inconsistent with UIP. I would have thought in terms of a connective tissue disease that we are looking at in this patient.
Okay.
Well, I know.
Yeah. So they have done biopsy, and I have taken, like, Sarda is the one who has taken, I think they have taken opinion from PGI Chandigarh. Sarda was the second opinion, and I will directly move to the slide. And this was the opinion from my own pathologist. We have third pathologist opinion. And just one moment, Sarda, I will just give it to you because my pathologist is not around. I will tell that she told extensive peribronchial metaplasia with mucostasis, interstitial widening, lymphocytic infiltrate, and her diagnosis also matches with like either UIP or fibrotic HP, which does not match in the clinical history. Now you can go through, Sarda, quickly. We can just have your comment about the slides.
So first of all, the biopsy is adequate because what I have seen is there are 4 fragments and each of them are more than 5 millimeters. So the adequacy criteria is 3 to 5 biopsies with at least 5 millimeter diameter. So the biopsy is adequate. And what I have seen in the biopsy fragments is one thing is the extensive peribronchial metaplasia, which is seen in this image along with this mucostasis. Some of these alveolar spaces are filled with this pink eosinophilic material. That is the mucostasis. And PBM is nothing but it is a metaplasia of the alveolar spaces which are adjacent to the bronchioles, where the normal flat lining epithelium is replaced by this bronchular epithelium, that is a columnar epithelium. So this is the PBM which we are seeing here. And apart from that, what I could see in one of the fragments is there is airway-centered fibrosis, meaning there is a bronchiole and surrounding that there is fibrosis, which is moderate to dense. So airway-centered fibrosis together with peribronchial metaplasia, extensive peribronchial metaplasia. And I couldn't find any honeycomb cysts. I couldn't find any fibroblastic foci or patchy areas of fibrosis, which are pointers for UIP. I couldn't find any of this. Apart from that, I couldn't find any lymphoid aggregates or increase in plasma cells, which usually favor the connective tissue disease. I couldn't find any granulomas or multinucleated giant cells, and I couldn't find any aspirated material. So my final impression is a chronic fibrosing interstitial pneumonia with airway-centered fibrosis with extensive peribronchial metaplasia. So with this histomorphological features, my first differential will be a chronic hypersensitivity pneumonitis, that is a fibrotic hypersensitivity pneumonitis. And the second one is the possibility of chronic chronic aspiration. And why I am not saying this airway-centered fibrosis can be seen in connective tissue diseases as well, but why I am not favoring CTD as my first differential, because one thing is I couldn't find any lymphoid aggregates with germinal centers, and there is no increase in plasma cells. What I found is there is lymphoplasmacytic infiltrate, but it is lymphocyte predominant. That is the thing. That is how I have ruled out CTD. And why I'm saying chronic HP is because airway-centered fibrosis with extensive peribronchial metaplasia. Peribronchial metaplasia
Okay,
is a soft
I
tube.
think, yeah, I'm sorry to
For,
interrupt you. I think that much pathologist is. So your final impression is chronic HP, fibrotic HP. You would not go into NSIP or CTD ILD because you didn't find the lymphoid aggregate.
Yeah.
Fine.
The
So
second possibility is a chronic aspiration.
sure. That is fine. So Vidya, you can just quickly tell the questions to the panel, and all yours. Anybody can take, please.
Can I ask something, the pathologist?
Yeah, please go ahead.
Yes, I would like to ask her if, as she put in the diagnostic yield, also the vaping aspiration, the vaping issue, did she see some eosinophilia, some eosinophils in the tissue that could be also related to a drug reaction, something like that?
I couldn't find any eosinophils in those parts.
No.
No,
And
she's
what I would
asking
like
is,
to, yes,
will it be seen? That's what she is asking. That if you are suspecting Willy or
yes,
something, will you
yes.
not find eosinophilic? Because one of the question which Dr. Vidya is going to ask is, can it be Willy? While Vimal Raj sir has definitely ruled that out.
Yes,
She
yes.
wants you to rule that out. That do you think this can be Willy, because she is expecting eosinophilic inflammation? So do you agree that it should be eosinophilic inflammation if it was weapon related lung injury or something? That's what she
No,
is
I
asking.
couldn't find. I couldn't find any features of E Valley.
Yeah.
One thing, I couldn't find any, diffuse alveolar damage changes. And the other thing is there are no smokers macrophages. There are few focal macrophages, but they didn't appear like, smokers macrophages. And there are no other features of smoking like respiratory bronchiolitis or emphysematic changes.
Sure.
What I would like also,
some,
what I would like also to suggest, in order to treat, because as you've said, maybe even if we cannot find any CTD features for the moment, as she is a woman, non-smoker, I would try, because there are some series also from the Brompton. Maybe Athol is not connected, he's in Rome, but there is some series with rituximab therapy in chronic HP in order to suppress the immunological component of fibrotic HP. So if the patient is under intensive, which I think we have to continue, oxygen rehab, etc., I would try instead of steroids or other MMF, etc., to go for rituximab in this lady.
Vidya, you listening, right? Okay.
Yes, ma'am.
Yeah. So is there any other question which you wanted? So no significant.
Actually, ma'am, we have
I can send you some literature later on, Asmita.
Yeah, I think other people also. So there were few more questions which were Vidya was putting for. That was no significant radiological improvement even after giving steroids, possibility of VAPing or possibility of CTD. So any of you, please, Parthasarthi sir, Shushmita madam, Rajan sir. ASW is it well? Athol sir? Athol well sir? I'm not sure.
Are there no giant cells, no, Sharda?
There
to
are no giant
suggest
cells.
that? So
No
that
giant cells, no granules.
you would see that in aspiration, right? If there were giant cells, a few.
Sir, aspiration, if it is only a gastric, gastric acid aspiration, then
Right.
there is no granulomatous pneumonitis.
Okay.
So the only changes will be like organizing pneumonia and diffuse alveolar damage.
Sure, sure.
We have rheumatologist also, Prithvi. She had ANA 3+ nucleolar pattern, and she has my positivity myositis, and she had, I think, Rho52 or something positive. So do
Yeah.
you think that was significant?
Uh,
I'll just
ma'am,
go through. 1 second. I'll just go through that again if I can.
Yes,
Was
ma'am,
Rho
Rho 52 was positive.
borderline positive.
Yeah, everything was borderline positive. So
yeah, ma'am.
yeah, here it is.
Yeah, ma'am. Regarding the ANIFA always should read with the in the context of the clinical scenario. So in this patient, there are no rheumatological symptoms as such, and the ANA is a 3+ nucleoral pattern. Based upon the pattern, mostly this fits into the systemic sclerosis because nucleoral pattern is mostly toward the systemic sclerosis.
Yeah.
But in the ANA profile which we got only Rho52, which is borderline positive, which is not significant for this patient.
Sure.
And coming to the myositis panel also, it is OJ borderline positive. If there is a OJ antibody positive, mostly the patient will present with severe form of myositis. ILD will be there, but they will have a severe form of myositis. So in this, only significant is ANA 3+ nucleolar pattern, but there are no features suggestive of systemic sclerosis in this patient. And other label we can put it as like IPAF, but it is not fitting into IPAF also because there are no clinical domains which is fitting into the patient. Only serological domain we have ANA 3+ nucleolar pattern. So it is not fitting into CTD ILD pattern or like any underlying connective tissue diseases.
I just wanted to ask, is it possible? What was he vaping with? Do we know what he was vaping with? Because his absolute eosinophil count to begin with was also raised. And also this would, fit, as she just said, with the pathology point of view, fits in with a chronic HP sort of picture. Was there any sort of hypersensitivity pneumonitis to what he was vaping? It doesn't fit with EVALI, even with the radiological picture or as well, because, it's all everywhere rather than just bases. So what was he vaping with?
Ajay
Ma'am,
or
actually,
Vidya?
we don't have a clear history on what he was actually using. He
Could
just
any of the inhalant have caused an HP-like picture, which is what we are getting on biopsy as well?
Yeah, we didn't actually get a clear history on what he was actually using. He just said he was vaping almost every day for a year. So we don't know what exactly it was, ma'am.
Yeah. Okay. You are muted, sir. Sir, Partha sir, you're muted. We have not seen
these are
Rajan
not-
sir. Yeah, you had seen.
These
So
are
I
not
was just-
features of EVALI on the biopsy, as far as I can see, Sushmita. It's usually diffuse alveolar damage, as Sharda said. What
Yeah.
you'd see, hyaline membranes, and that's what's being described.
Yeah, that's what I said. This is not EVALI, but is this HP from what he was vaping? Because it's an inhalant that's gone inside and
Okay.
caused a chronic HP-like picture. Not EVALI. This is not EVALI for sure.
Yeah.
Yeah, I was
Exposure
pondering
to
had it been a classical HP, there would have been peribronchial pathology to start with. As we have seen, there's nothing peribronchial. It's quite atypical for that. What I find and what the pathologist Dr. Sarda described, that the alveolar epithelium is replaced by a sort of bronchiolar epithelium. This is something quite unusual for a HP to start with. It might, I do not know, I don't have much experience about it, and pathologists can say, but an HP to begin without peribronchial involvement is quite odd. And if you see the CT scan, the upper lobe involvement anteriorly and the lower lobe involvement posteriorly, that fits to a description of CTD-ILD. And if you ask about the 3 criteria of IPAF, you have no clinical criteria, you have a serological criteria, and morphological criteria is also positive. The description can fit with a collagen vascular disease. So why not an IPAF? So
So
these
it
are the
is
things which are crossing my mind.
Yeah, it is airway-centered fibrosis, sir, and peribronchial metaplasia is more a clue for HP rather than a CTD.
Okay.
Yeah.
And
but-
the nucleolar positivity of ANA has been regarded positive as a serological criteria for IPAF, even if it is 1:160 in as titer. So I think, can it be a case of a IPAF?
I think even
This
Vimal
chap
Raj
also
sir
had-
was telling about CTD ILD diagnosis, and we have INA 3+ positive. What do you say, Rajan sir and madam and Katrina?
This is lung restricted IPAF
Yeah.
or
No, there's too many differentials here. We are not getting to a
Yeah.
working diagnosis actually.
So
So
biopsy actually doesn't fit into CTD.
No, so this chap
Yeah.
also had a lot of pigeon exposure before, didn't he?
Yeah.
So did he
Pigeon
have a
and mold
background HP?
exposure. Yeah.
He have a background HP on top of which there's a second antigen which is hit, or which the HP could be just a background thing that he
Sure.
has.
Sure.
Yes, I also think, Suji, that as the madam said, it could be just a reaction, but not the real disease, the HP.
Yeah.
However, whatever the disease is called, we can also classify as unclassifiable because, as
Yeah.
you know,
Yeah.
there are a lot of
Yeah.
series also
Yeah.
from US where there
Yeah.
is a percentage of 25% and more of unclassifiable fibrotic bug disease. So we don't have to put a name, IPAP or whatever. Or
Sure.
I think that covers this
Yeah.
umbrella of what we have
Yeah.
discussed, and it was very nice discussion.
Yeah.
I
I
would
have
have put
one
this
What we
question.
as
can do
probably, yeah.
further
Yeah,
Yeah.
I would have probably
to help
put
the
this as HP with low confidence or unclassifiable. I agree.
Okay. My one question was to Dr. Katrina or any of the panel. So if you are putting a diagnosis of unclassifiable ILD, what treatment? So should we go by radiology? Like we should just go by radiology,
What has she been treated with so far?
Vidya?
He's treated with steroids, sir.
So
Almost.
how long and any
It's
improvements in lung
almost
function?
lung function is yet to be repeated, sir.
Okay, so I
On the
would
next
repeat.
visit, we are
Yeah, I
planning
would,
to repeat a CT and then along with PFT.
But
sir.
we have already 3 CT scan, Vimal Raj sir. Do you feel it is improving or is there worsening?
I
There
think
is
Vidya,
no change in the
no
last
change.
3
There's no
scans.
change.
So
There's no change at all. So
Yeah,
I
it's
would
Yes,
all
re-
look
why
identical.
Yes, that's why I told you, I suggested that maybe you can try to increase the antifibrotic treatment to treat the patient as PPF. Because
but
But
Katrina, she's not
lots of
falling.
ground
But
glass.
Katrina,
procedure
she's
there,
yeah.
and she's behaving like a fibrotic patient, and I would add some immunosuppression like rituximab because
Okay.
Rituximab. Okay.
So I'm just thinking I would do the rituximab if there was at least a steroid response on her vital capacity. Don't you think, Katrina? I mean, we would have to have gained something because we haven't repeated a second lung function. And we don't have evidence of progressive fibrosis on her scan. Neither is she getting more symptomatic, right, Vidya? She's just the same.
He's actually symptomatically better, sir.
She's
Much
better.
better.
So I was just wondering whether
It's a
you'd like
male
to wait.
patient, he's better.
Male page, yeah. Whether, Katrina, we should wait on the antifibrotic symptoms are better, CT is not progressing, and lung function, we don't yet have a second lung function.
And if I have to add second drug, why not MMF? Because that trial is also going on, isn't it? CTD or even HP. Addition of MMF we can do because
I like a lot MMF, dear Asmita. I think that if you know the patient better, if you have a patient in front of you who is relatively stable, I would go with MMF.
sure.
If you have a patient who is at risk, I would like to try
Sure.
IV
Okay.
rituximab. You know
Got it.
better.
Yeah, got
But
it.
I would, yes, but I would keep the antifibrotic.
Sure.
Sure. Why
So
would you want the antifibrotic? Just because it's unclassifiable, Katrina? Or any particular reason?
Think that as far as I understood from the CT,
Yes.
the lower DLCO of 30%, 35%, and she's under oxygen, I think that there is a fibrotic procedure there, which maybe it is not a classic one, but I would like to have a nintedanib to 100 twice a day, not 150, 100 a day, and to add or MMF or something more aggressive according your
Okay.
the physical appearance and the physical, how the patient feels and the her preferences, because
Got it.
also it's also nice, I think, to take in
Yeah.
consideration.
And
Sure.
maybe
Yeah,
repeat
basically, I
what
think
we
you're
see.
suggesting she has progressed from somewhere. We don't know from where. Even though the 3 serial CTs are the same, she's obviously had a baseline which was better, and now she's got worse. I think from that perspective, Vidya, she's oxygen dependent now.
No,
Vidya?
no, no.
Oh,
The
Yeah.
patient is
on
98%
sir.
room air.
Maybe a
Thank you.
repeat FVC and
He
VLC
visits us
will
on
be.
OP basis, sir. He was having 98% on room air.
Okay.
May I interrupt, madam? May I interrupt
Yeah,
on Dr.
Ajay, yeah, please.
So it's under my follow-up. So this patient actually is doing quite well. No exercise limitation at all. He's going regularly to the gym, and his exercise capacity, everything has considerably improved after starting the steroids.
So that's very nice. So MMF, I think, is much
Yeah.
a
I
very
would
good
also look at
suggestion.
MMF. Yeah, that makes sense.
Yes, and so in this case, if she's doing so well under steroids, I would like to have her under the minimum dose to have MMF in the meanwhile, and not to introduce nintedanib. I understood that she's progressing, but she's improving. So
Yeah.
Yeah,
So
I think we could probably
Good.
give MMF. I agree with you, Katrina. That makes sense, and
Yeah.
in such a patient, and keep a close follow up on lung function, Vidya. I'm
And
sure the
repeat the
PFTs
FVC
would be
and
better
VLC.
now. You know,
Yeah.
Yes, sir.
Yes, sir.
So actually, this is PFT is being planned for the next week. Actually,
super,
we were tapering the steroids, and is right now on just 2.5 milligrams of isolones per day.
Sure.
fantastic.
So
Sure.
we are planning to stop it. So whether to add an MMF together,
Yes, yes.
stop it and observe, or just
No,
add an
add
MMF.
MMF.
I
Add
think the
MMF.
disease activity is still there, Ajay,
Yeah.
because we can see the CT
yes,
scan.
yes, I would decrease the steroids and I would
Add on.
introduce MMF in order
Correct.
to give a little bit of time, because in order to, let's say, have the maximum effect of MMF, we need at least 3 to 6 months. So in the meanwhile, we have to keep the lower possible doses of
Steroids.
steroids.
I think
Sure.
5 milligrams should be good enough.
Yeah, good enough, good enough. So this is an
Yeah.
interesting case in which we have a pathology diagnosis of UIP or fibrotic HP. We have radiological diagnosis of CTD ILD, and we have clinical diagnosis of unclassifiable ILD. Are we
Yeah.
right?
So Ajay,
Okay.
yeah, it's unclassified. And Ajay, probably you'd like to go to on the specifics. Maybe she's on 2.5, right? Continue that for some
Okay.
more time, maybe 4 weeks, then make it alternate days and get the MMF up to 2 grams a day after a
Okay.
fortnight. So 1 gram for the first 2 weeks and then push it up to 2 grams. I know globally they give up to 3 grams in a day, but you may want to be careful. What's her weight like?
He's around 70 kg, sir.
70.
He's
So
a
you
healthy
could
man,
go up to
healthy
3, but
muscular man.
we most often give 2 grams a day. Katrina would have more experience with 3 grams.
Yeah,
I'm not
but
sure.
we will go slowly,
I
sir.
think
Yeah.
yes, I think that I do like you. I usually do not go over 2 grams, and
Sure.
I usually have a regular dose of 1 gram and a half for maintenance.
Sure.
So
So
moving on to the
maybe-
last. Yeah, please
Super.
go ahead, sir.
No, just maybe get up to 2 grams and then maintain at 1.51 and monitor
Sure,
lung function. After a year or 2 years, they invariably get fed up
Yeah.
of the
Sure.
MMF. So you have to take a trial of cutting back on that as well.
Sure.
Okay.
Great case, yeah.
Thank-
Great case. Interesting.
Yeah.
Thank you, sir. Thank you so much.
Interesting,
Thank you,
interesting.
ma'am.
We have never seen this vaping-induced lung injury, so we were not expert to do it. But I hope you are okay with the answers.
So
Okay.
Bhavin and I had published one case, Smita. One
Yeah.
of the first cases, in fact. Bhavin will remember that.
Yeah.
And
Please go
it was
ahead. It will be interesting
diffuse
to
ground
hear.
glass.
Yeah.
Yeah, diffuse ground glass. We didn't do a biopsy. She's a young lady, and the radiologist got the history of vaping because they asked her. Actually,
Wow.
I didn't ask her because
Yeah,
they.
yeah.
I have to give credit to Bhavin for that.
Yeah, it was a focal OP, na? So we called and she was
Yeah.
very reluctant to give that history. but she finally did. And then she even brought the vaping fluid to us.
Mhm.
With that. But vaping it does not commonly produce fibrosis. And so the whole issue here is that whatever it is should have resolved on its own at some point in time, which it hasn't. And which is why I think we've got this whole problem. So
I think Bhavin, the thing was whether it's a chronic vaping related HP causing fibrosis. I think
it's
that was
possible,
the
but
thought. It's far fetched, but I think we finally have to boil down to unclassifiable here. Katrina's right. That's
Yeah. Okay, that was great case. Thank you, Ajay, for that. And I will move on to my case, and I will as quickly as possible, run through my slides. So this is like I am surprised to see, because usually 72 years old man comes with fibrosis and all is very common, but this is 72 years old lady who came with a typical complaint of progressive dyspnea. She had significant history of papillary micro adenocarcinoma, and she was having surgery for that, history of COVID-19 2021. And any COVID is always labeled as like post-COVID, anything happens is contributed to COVID. So there was COVID in 2021 requiring home quarantine only. She had coronary artery disease, and she had mild mitral stenosis, MR, mild pulmonary hypertension. I'm not sure because of MS whether pulmonary hypertension is related to her valvular heart disease or her pulmonary problem, but she has on the echo, and she had history of hospitalization in February 2024. When was the first CT scan? That was the time when the first CT scan was taken, and they found out that there is something wrong in the lungs also. She had some non-specific osteoarthritis of the knee also. So she presented to me with complaint of cough, scanty expectoration of almost 2 to 2.5 months. All this while she was okay. That's what she said. When she came, she had grade 2 dyspnea. She had exposure to rubber. Rubber is a quite common like a plantation in Kerala, and she had those exposure for last 10 years. But no history of any exposure to pets or anything, no family history or no history of symptoms of connective tissue disease stigmata. Her general examination is quite uneventful. Her saturation was 94% on room air. She had bilateral V's and fine crepitations. Her other things were normal. Now moving to ANA profile, and Prithvi, you have to help me out. So you can just start talking, interpreting the report if you are there.
Yeah, ma'am.
Yeah, please go ahead.
Ma'am, regarding this patient rheumatological profile, ANA it is 2+ cytoplasmic. Generally, we will consider more than 2+ as significant ANA. And coming to RA factor, the normally here it will be 16, it is 20, not too much elevated. Anti-CCP is less than 7. Anti-PR3 MPY is negative. ESR is high, LFT is almost normal. So I would rather say in the ANA profile is negative. This is the myositis profile. In the myositis profile, MI2 is borderline. So PMSCL 75, it is positive 1+. So we can take that 1+ into account, that a myositis profile. We can say it as a significant. But PMSCL, anyway, it will have the features of polymyositis and scleroderma overlap. So they will have a like myositis features plus skin tightening. Any scleroderma features will be there. But
she didn't have any, yeah.
Any of the features. So
she had like, if I ask her whether she has difficulty in getting up from the chair, she told me, but she had osteoarthritis of the knee, and I was not sure because I didn't find it was muscle weakness related. So I would rather say it was her age, 72 years and all, and we can directly move on to CT scans.
So we have the CT scan. So quite nicely, as Ashmita said, few things just for interest. There's a lot of calcification that we can see along the mitral valve across here. This is all in keeping with mitral stenosis. She also has a mild component of aortic stenosis and coronary artery disease and pulmonary hypertension. Now, these are the inspiratory and expiratory images, and what we are seeing here are these bronchocentric areas of ground glass opacities, and with some associated traction dilatation of bronchi, upper lobes and lower lobes involvement is there. And straight away, what we are seeing here are these triple density signs, areas of air trapping, areas of normal lung, and then ground glass opacities associated. And on expiratory scan, we are seeing some of these areas becoming more prominent. So this all looks like a fibrotic interstitial lung disease. Pattern is inconsistent with UIP. I would have thought this as a fibrotic HP that we are dealing with.
Okay. Okay, I will just put my questions. 1 second. So we saw the CT scan. She was started already by orthopedic with some medicines. I saw the report of ANA 2 plus, and because she was, did I show you the PFT? Yeah, this was her pulmonary function test, and she was desaturating. She was symptomatic, and she was having cough. So I saw the findings, and I have started her on prednisolone 30 milligram last week when the relative came with the CT scan CD, which was done outside. So this is summary of the findings, and my question will be, is it CTD, ILD or fibrotic HP? And sir told it he will treat it as a fibrotic HP rather than that. And any chance of COVID fibrosis, sir? No, right?
No, the
Because,
pattern does not fit in with that.
yeah.
No.
And the question to the panel is, should I continue steroids or add an MMF? Because she's 72 years, already osteoarthritis, already started on calcium replacement, everything from other side, and the relatives are also concerned, and any role of antifibrotic. And do we need to do biopsy? I think those are my questions to the panel.
Did you do any bronchoscopy on this patient? Any
Not
bag?
yet, not yet. I have given only 1 week of steroids that time. And then because she was symptomatic, I just wanted to give some region therapy by the time I discuss. So I can do, she is fit enough to do 72 years, but I can do bronchoscopy, no issues.
Yeah, I think the BAL might help you because initial history and the rheumatological picture that you presented, I was thinking it must be MCTD ILD, but the
Sure.
CT definitely looks a lot like fibrotic HP. So
Yeah.
maybe a BAL will help you.
Definitely, I will try.
Can you
Bhavin,
put your
sir?
questions up,
I will.
Asmita? Yeah. Sushmita, you want to go on the other questions before I
Where's the others?
tell Asmita my thoughts?
Yeah, should I continue steroids or add on
Do your
MMF?
BAL. Do your BAL.
After BAL and then decide. Yeah, if BAL is lymphocytic, you want me to do BAL because to find out is it lymphocytic. But if it is a fibrotic HP, do you expect lymphocytes? Because I am not sure of that.
See, the first thing is that you said the exposure was 10 years ago. So whether
Yeah.
at all it is rubber that is causing the HP, we don't know really, do
So
we?
look. I think the plantations are still there. Maybe she was working 10 years before and now she's old, so she's not exposed. But it might be still in her surrounding. You know, this rubber plantation and are all on the back side of their home. In Kerala, it is like that. So I'm not sure what kind of, I'll find those details from the history.
Yeah. And regarding antifibrotics, after giving a couple of weeks of steroids, if she's still desaturating, I would definitely add early antifibrotics to this patient because there
Sure.
is already fibrosis present. And I would probably not biopsy her.
Okay.
If that gave me the results.
Yeah. Sir?
So Asmita, quickly, I mean, I'd also love to hear what Katrina has to say. Fibrotic, can you keep the questions, Asmita?
I think Katrina has left. I'm not seeing
Okay, no
her.
problem, no problem. So
Okay,
this
okay.
looks definitely fibrotic HP from the CT scan.
Sure.
Most certainly fibrotic HP. I would continue. I mean, now that you've taken a decision to give steroids, I would have probably had a conversation with this lady about the side effects of steroids at the age of 72, and probably even considered an option of MMF alone and not steroid to start off with, unless she was very symptomatic. Was she very symptomatic, Asmita?
I think she is more scared of steroids rather than her symptoms, I would say.
So yeah, so in such a lady, I would probably agree with Sushmita. Maybe ideally BAL if you have the setup to do that, and the patient was willing, and then consider MMF over prednisolone. No antifibrotics for now,
Sure.
and biopsy. I think I would. I mean, again, that's a conversation with the patient, but I don't think management is likely to significantly change with a biopsy,
Sure.
and so I wouldn't do it.
I think that's fine. Anybody wants to add upon anything? Otherwise, we are 6 minutes behind the schedule, but we did a good job. And I think thank you so much. We had many new people today, and Sharda did a wonderful job. Even our rheumatology, Dr. Mithun has to go like because of emergency, and Dr. Prithvi was with me today. We have Vidya, who was Vidya and Ajay team presented a new cases, and most of the
Good
cases, most of the
We have
cases we
cases
were.
for next time also. A lot of actually cases now wanting to come in here. Are we offline with the audience or we still with the
I'll 2 minutes, sir. I think Dinesh, 1 minute, please. We had around 38 users and we have 17 participants from our side, and all those who have joined from the delegate side. Thank you so much. And no questions today. Otherwise, I would have entertained that also. Thank you so much. Looking forward to see you next time. That is 7th of June. And we have got 2 pediatric cases. Which will be presented, one from Gujarat and one from Kolkata, and one more case has come from Mumbai, from Tata Memorial. 3 cases are already there, but as we can see that if we would have finished few cases faster, we could have included 4 cases. So definitely one more place we can include. So I think that's it.
We are aiming for
Yeah, we
20
are aiming
in 2
for.
hours. And so therefore 10 in 1 hour. And the only way we can do that is, Asmita, if you just rapid fire, like
Yeah, I
one
know,
or two
I know.
slides,
I think
one
we have
scan
to,
and
yeah.
questions, and
And
then just
I'm sorry, devil's advocate. If you're
Yeah.
Sujit, when you went to the Brompton and did that MDD, they are in an institute. They are the same set of people meeting each time. They know exactly. Sometimes they can read each other's minds. I mean, so you can do 10
No, I got
cases.
your point. No, I'm
I
not
think the
saying
pro forma,
do 10,
I think
but we
sticking
can
to the
do.
pro forma will be good. Sticking to the pro forma for every presenter will be good.
Yeah, I
Yeah, so
know,
they had
I
a lot
know.
of outside external consultants also coming there, Bhavin, who would like come present their case and then just leave once the decision was
Correct.
taken by the MDD.
Correct.
So I mean, the fact that they could do 20 in 2 hours means I'm not saying we need to do 10, but I think we can easily do half a dozen in an hour.
No,
Is
we
is
can't.
my thought.
We
Yeah.
can't. Not
We
not
can't.
because we're not in the same institute. The whole the
Yeah.
way the information that we have is not consistent
Yeah,
across.
that is true.
Our
That is true.
scans are not consistent. There are so many issues there. So
Got it.
if Sujit, we were doing only your cases in your institute, and then physically, if people were coming in with their cases,
Yeah.
that's different.
Yeah.
When we
So,
do a
so,
bone
so
and
the
soft
idea,
tissue
yeah,
MBD, we can do 10 cases in an hour. That's not an issue. But
I got your point. I got your point. I'm just thinking that the idea is to push the presenters to improve the radiology, improve the presentation so that they're quicker. That's what I thought
I
should.
think clinical presentation should be less than 3 minutes to 4 minutes.
Yeah.
It should be
Yeah.
snap,
Yeah.
quick. And in
Sure.
fact, information on the slide doesn't have to be repeated. So
Correct.
the
Correct.
slides have the information. We can read it. The
Yeah.
person is giving us the salient features, and we should be done. Same
Yeah.
thing.
Yeah.
Yeah.
Vimal and
I
I
think
worked with Pat for
I
the
think
CT, not more than
correct.
3 minutes to describe the
Yeah.
CT scans.
Correct. Correct.
One second,
last
Actually, no one is
Dinesh,
used
can
to
we just
MDD.
make it offline, please, for us?
It's
We
not
are
off.
offline. We are offline.
Okay,
I think
thanks. Yeah.
we just ask them to stick to pro forma. I think stick to pro forma and give them that amount of time to present. And
Yeah.
that is how they need to present and make it really slick, so
But
that it doesn't
it
take time.
Which is why
happen. There are-
Sushmita, myself
Sorry.
and Asmita are trying to present as many as possible, so that they
Yeah.
get the idea, the
But-
hang of it,
Yeah.
But when you have new people, so now the pediatric thing that is happening
Yeah.
now, there is no way each case will take half an hour because you've got a whole set of new people coming in. The
Yeah.
pediatricians, the pediatric rheumatologists, the pediatric pulmonologists. So each one of them, even if they take five minutes to describe a case, you straight away got, 20, 25 minutes gone. So it's only when you have a familiar set of people that you can move fast. Otherwise,
Yeah.
and it's okay, na? 3 cases in an hour is good enough, yeah, for the time being.
It's good. Yeah, no. For the time being, it's fine. I'm just saying we should always aim to get better. That's all. Nothing else.
Yeah, I agree. For that, I agree. Totally agree. But 20 cases to हमें मार डालेंगे. So I don't think.
Possible
just-
nahi hai. We
Good
won't
enough.
be able to do justice to 20 cases. I
I
think
know.
3, max 4. Last time we did 4. That was
No,
good.
no, and 20 was in 2 hours, not in 1 hour.
Yeah,
So,
yeah.
so we.
So is Vimal doing 7th June or?
Bhavin, I think you will have to do. I am not available 7th.
Okay, 21st, I am not in the country. So can you take care? I will be joining in also. So.
But you're allowed to join from outside the country also, by
I'm on vacation and the wedding in Barcelona. I think they're just going to kick me out from the wedding.
No, but one more thing, the list which you sent to us, I have, when I presented that MDM meeting, I knew that consensus diagnosis and unclassifiable and the confidence of which we,
Yes,
so
yes.
I have added it. I'm not sure whether you saw that Google sheet which I have shared. So Bhavin sir asked me to add all the cases. So we have
Excellent.
Excel sheet and
Perfect.
we are changing whatever is new we have to add. Second thing is in 20 cases, sir, which Sujit Rajan sir is talking about, there were 15, around 10 cases, which was just radiology discussion. There was
Yes, yes.
nothing else. So
But that is ILD management in India, Asmita.
yeah. So that's
Yeah.
what I'm trying to say, that we will
Right.
reach to those level in which people have to realize that the reason here we are not getting even questions clearly,
Sure.
they are not clear
Got it,
about
got it.
why they are putting the case in the discussion.
Absolutely,
So
absolutely. Even if
if
we
I
have
will,
one, see, assuming we reach the level of 6, okay, even if you have one or
yes,
two with a biopsy, that's great. I mean, Sharda, I'm meeting for the first time. It was a fantastic input, Sharda.
yeah.
Where are you from, Sharda?
Sir, I was in Mumbai only till last minute. Bhavin sir knows me.
No, so
We are
we will
lucky to have you, Sharda. Thank you.
Thank you
these
so
are
much,
very
sir.
precious people, lung
Yeah.
CT
Sir, I'll
radiologists,
come back.
lung
I'm coming back.
pathologists.
Sir, I'm coming back.
Yeah, you
Okay.
be prepared for her, and it was really great discussion today. I think we did a good job, even though we started very slowly, but we picked up. And the second case was great,
Yeah.
and my case was, anyway, I will put my case last because I can wrap
I
it
think the
fast.
important thing is that the presenters feel that they got what they wanted. That's
Yeah.
most important, because they're bringing
Sure.
their case to the MDD for further guidance. And between Sushmita, Partha, myself, and Katrina, if we couldn't give them that, then I think they will feel, disenchanted, which I think there should be that reasonable consensus within the group.
Absolutely.
And
I agree.
And we should also
Partha's
get
network was bad. So if Partha, I've noticed this on a different webinar also, his network is often bad. So we need to tell him when he comes in to get the network issue sorted out.
Yeah.
I'll tell him.
Yeah.
follow-ups as
Sushmita
well.
bol dena.
Yeah,
We need
Bhavin sir.
follow-ups also
Yeah, I saw in MDM that the people who are putting, so what I have to do is they have a prepared ready-made sheet like that, in which they write the plan, what was the diagnosis, consensus diagnosis, confidence level of diagnosis, and treatment plan has to be mailed properly to the people who have sent us the case. That is what is ideally being done in the Royal Brompton, if you that is what
But
you are
there
asking.
it's binding, no? So when an external consultant requests for an MDD and
Yeah.
decision is taken, then in the NHS, that is a recorded thing. So once it's
Yeah.
recorded in the patient's EHR, the consultant has to go by those findings and do it. See, वो practice ही अलग है ना, अपना
Yeah.
जैसा practice तो नहीं है वो लोग का.
Correct.
So
That
that
is
is a
for them.
formal thing. It's not like
And
ours.
also for them, it's not for the diagnosis, it's also the expenditure of the treatment that's going to happen, that it has a
Right.
consensus,
Yeah,
which
yeah.
is how to do it.
And I think, Asmita, one other thing was, I know we want to distance ourselves from pharma on this, and that's a good idea also. But if we at all you look at pharma funding, maybe for a secretary, I'm just thinking, because that person the monies from pharma could be utilized for that. In
So,
a way,
yeah. So coming
I'm
to
just
that,
thinking.
so I'm a kind of person who, if the person does not understand my frequency, I would rather do myself, because
So
it is
you
double
interview,
work. Yeah,
you
double
interview,
work to make
you
somebody work. Yeah.
so
So I
we'll
had to. That's
interview
why
him.
I told.
You
Yeah.
need a tuning for matching frequency.
नहीं नहीं सर, मालूम हो जाता है, एक बार बात करने से मालूम हो जाता है.
हाँ तो इंटरव्यू करो ना बस we have to just interview and then you'll know whether tuning सब है कि नहीं.
चलो guys, yeah,
ठीक
Friday.
है, bye
चलो.
bye,
Bye. It
thank
was
you,
good.
good
Bye,
night,
Vimal.
good
Bye.
night,
Bye.
good night, good night, great.